Cow's milk protein allergy is a very common problem and easily misunderstood and easily mismanaged problem. So therefore, I thought that it is appropriate for me to discuss about this to uh, clearly identify managing and desensitization to be done by uh, pediatrician and pediatric trainees as well. So when it comes to cow's milk protein allergy, it's called CMA or cow's milk allergy. The prevalence in the population is between 0.25 to 4.9, but the most recent research papers say it's close to 6%. It's higher in children than in adults and high in referred population. The referred populations are populations or the patients who have allergy and asthma. The prevalence of cow's milk protein allergy peaks in infancy and falls less than 1% by the age of 6 years of age. About 10 to 15% of children who have cow's milk protein allergy are also allergic to soya. So the cross allergy is more common if the symptoms occur below 6 months of age. Easily misdiagnosed condition with the cow's milk protein allergy is lactose intolerance. So you come across patients who are having real lactose intolerance who have been managed like cow's milk protein allergy or vice versa. Cow's milk protein allergy is due to a reaction, immunological reaction in the body to one or more milk proteins in the body. And it is different from the lactose intolerance, where the allergy is due to, is not allergy, it's a reaction to disaccharides making the lactose in the body. So when I compare cow's milk protein allergy with lactose intolerance, cow's milk protein allergy is an IgE mediated or non-IgE mediated allergy, whereas lactose intolerance could be congenital or primary or secondary, which happens after severe gastroenteritis or other causes of enteropathy. IgE is an immunological reaction, whereas lactose intolerance is due to quantity-dependent lactose ingestion. Cow's milk protein allergy is a multi-system disease which involve gastrointestinal, skin, and respiratory systems, but whereas lactose intolerance is only gastrointestinal problem. The natural history of cow's milk protein allergy is that it recovers by 4 to 5 years of age, and lactose intolerance usually will recover within days or maximum weeks. But whereas in primary or congenital lactose intolerance, it's a permanent disease. It is congenital. When it comes to cow's milk protein allergy, there are two types of immunological reactions. It can be either immunoglobulin E mediated or non-IgE mediated cow's milk protein allergy. IgE mediated cow's milk protein allergy is due to mast cell degranulation and release of histamine from the mast cells. Whereas non-IgE mediated cow's milk protein allergy is due to a T cell activation and releasing of human necrosis factor and interleukin 5. Now, when it comes to symptoms, in IgE mediated cow's milk protein allergy, you usually get a reaction within 2 hours of ingestion of cow's milk, and usually the reactions are pruritus, acute urticaria, acute angioedema, nausea, vomiting, lower upper respiratory tract symptoms, or anaphylaxis. Whereas in non-IgE mediated allergy, cow's milk protein allergy, it could be atopic eczema, gastroesophageal reflux disease, blood and mucus in stool, colic, constipation, and also respiratory symptoms. So I will be discussing these things in detail at the latter part of this lecture. And you also can have a mixed pattern of IgE and non-IgE mediated cow's milk protein allergy together in the same child. So immediate reactions of IgE mediated cow's milk protein allergy are angioedema, urticaria, acute pharyngotic eczema, and gastrointestinal symptoms like vomiting, diarrhea, colic, which will happen immediately after ingestion of cow's milk. And you have this severe reaction of anaphylaxis in certain patients, which are quite rare, but it can even be life-threatening. So the features of sudden onset anaphylaxis could be urticaria, dyspnea, hypotension, hypotonia, and shock. In addition to that, you can also have IgE-mediated cow's, also non-IgE-mediated cow's milk protein-induced enterocolitis syndrome, which can happen during first few months of life, where you get repeated episodes of vomiting, sometimes leading to dehydration, and symptoms may be very severe and can mimic sepsis. So usually there's a gap between, in this particular condition, there's a gap between the ingestion of cow's milk and occurrence of vomiting and diarrhea, which could be even few hours. So the direct reactions in cow's milk protein allergy are milk-induced enterocolitis, enteropathy, and proctocolitis, and the patients present with rectal bleeding. So rectal bleeding in a normal infant who is behaving normally, who does not have sometimes vomiting, who does not have fever, you have to always suspect that the child is having cow's milk protein allergy. So other symptoms could be diarrhea, mild to moderate steatorrhea or bulky stools, poor weight gain. If the cow's milk protein allergy persists for a long time, it can lead to poor weight gain, and also it can lead to lactose intolerance and also perianal exportation. So this type of symptoms also can happen with other proteins like fish, chicken, turkey, corn, or vegetable allergy. And you have this condition which is called eosinophilic gastrointestinal disorders, where the patient can have eosinophilia and also eosinophilic esophagitis, similar to GE reflux in children. And in adults, this can present like dysphagia, food infection. And also the features of this condition is failure to thrive. You can have chronic anemia and deficiency anemia if there's chronic enteropathy. Delayed reactions also could be atopic dermatitis, which can happen in 10 to 15% of children, and some of them can have cow's milk protein allergy. And there's a rare condition called Hayner's syndrome or milk-induced chronic pulmonary disease, where you can have pulmonary infiltrates, chronic cough, recurrent fever, tachypnea, and failure to thrive. So this is the common differential diagnosis of cow's milk protein allergy. You can have infective colitis type of symptom. Celiac disease is another differential diagnosis. Gastroesophageal reflux, as I told you earlier, could mimic cow's milk protein allergy, and also eosinophilic gastritis and immune deficiency. And also there's this common misnomer among the general public that dairy products can increase the production of phlegm in the respiratory tract or mucus in the respiratory tract. There's no scientific evidence for this. So this cannot be put into the category of cow's milk protein allergy. Then we come to the next part of the lecture, how the diagnosis of cow's milk protein allergy is made. Most important thing in diagnosing of cow's milk protein allergy is comprehensive history, including a family history of atopic. Physical examination, I'll explain, and there are no one symptom that is pathognomonic or identical of cow's milk allergy. Timing and pattern of symptoms can vary, but it can occur at any age, though it is common in children. So any patient, you have to consider cow's milk protein allergy who are having this type of large array of symptoms. So it's extremely difficult only through the history to diagnose cow's milk protein allergy, unless it happens immediately after cow's milk ingestion. It's difficult to diagnose sometimes. So what are the diagnosis tests available? So if it is a IgE mediated cow's milk protein allergy, so it's very important to identify that by the skin prick testing, what you can diagnose is only IgE mediated cow's milk protein allergy, not the non-IgE mediated cow's milk protein allergy. So skin prick testing is one method of diagnosing cow's milk protein allergy, and reaction of more than 3 millimeter is considered as positive in skin prick testing. Then you have specific IgE levels for cow's milk, which could be done as a blood test. The current cost is about 5,000 rupees. You can get false negative. It's like the patient who is having cow's milk protein allergy, IgE mediated cow's milk protein allergy, can have a negative test if the patient is currently on total cow's milk avoidance diet. And also you can have false positive by misinterpreting the result. So it is very important that you read the legend at the end of the test report, where it says above a particular level is only considered as positive. So any level above normal is not considered as clinically significant. Clinically significant significant levels are mentioned at the end of the report. So it's very important when you get a positive result to compare it with the legend of the test report. The other test that you can do is the skin testing, which is hardly done, but it's a reliable method of diagnosing non-IgE mediated cow's milk protein allergy. The other method is elimination and challenge testing. So that's a definitive procedure of diagnosing cow's milk allergy. So what you do is, after 2 to 4 weeks of elimination of diet, if the symptoms substantially improve or disappear, and after introducing of cow's milk after 4 weeks, the symptoms reappear, then it is very confirmatory of cow's milk protein allergy. So if the reactions are immediate, it's very easy to diagnose. But if it is little delayed by days, sometimes difficult to diagnose. But however, elimination and challenge test is a test which is considered as very valuable in diagnosing cow's milk protein allergy. Open challenge is hardly done. It's very dangerous to do, especially in children or people who has had severe reaction to cow's milk allergy. There it is done under very controlled conditions. So how can you prevent cow's milk protein allergy? It has been proven scientifically. Best way to prevent cow's milk protein allergy is exclusive breastfeeding for 3 to 6 months. So incidence of cow's milk protein allergy is lower in exclusively breastfed children in compared to formula-fed or mixed-fed children. Then we come to the third part. How do you manage cow's milk protein allergy? Number one is avoidance of cow's milk protein, which is almost impossible. But if it is a mild type of a cow's milk allergy, then you can manage by doing this modality. So by strictly avoiding cow's milk and cow's milk protein based products, example yogurt, cheese, butter, and mothers who are breastfeeding children with cow's milk allergy should continue breastfeeding, but the mother should avoid taking milk containing foods. And you must tell them to read the labels and identify cow's milk protein containing products, and also get advice from a dietitian about the balanced diet, because the child will be on non-milk diet. Then you have incomplete milk avoidance in these severe cases, limited use of milk, and also you can use extensively heated milk. Heated milk will denature cow's milk proteins in the milk to a certain content, and boiled and powdered milk are also very helpful because they are heated up to 200 cc. Powdered milk are less allergenic. And then you can use alternate formulas such as extensively hydrolyzed formulas, which are commonly available, but amino acid based formula, which are extremely hydrolyzed or broken, the protein is broken into amino acid itself, is the one which is used in severe cow's milk protein allergy. Other formula that you can use is the soya formula. But remember that 10 to 15% of children who are having cow's milk protein allergy are also allergic to soya. And soya is not recommended, soya milk is not recommended under the age of 6 months. As I said earlier, partially hydrolyzed formula can be used in mild to moderate cow's milk protein allergy. So it is not recommended to use milk substitute and also other types of milk in cow's milk protein allergy because of the cross reaction with the cow's milk protein allergy. So how do you follow up patients on total exclusion? So milk is excluded from the diet. So therefore, very important that you monitor the growth and control the coexisting disorders, and then prepare for emergencies if there's a accidental ingestion of cow's milk to take action, and also train the parents and the teachers if possible, when possible, to take action on emergencies, which the key drug that has to be used is adrenaline. Then I come to this specific oral tolerance induction, which is also called oral food challenge or allergen immunotherapy, where in a child, in selected children who are having a specific IgE type of reaction to cow's milk protein, where the milk is introduced in graded fashion starting from a very low concentration going up to a higher concentration. And at the end of this procedure, the child would become non-allergic to cow's milk. So the key to this procedure is that careful patient selection. So this would work only in patients who are having IgE-mediated cow's milk protein allergy. So how it is done by us is that a solution starting from a 10 to the power minus 6 from the desired dose, which is 5 ml of milk, is made, and it is given in 18 dilutions gradually over a period of 6 days, and the child become non-allergic to cow's milk after that. So at the end of 6th day, the child would have 5 ml of milk without any reaction. Then you gradually go on increasing it by 5 ml each day, reaching up to the level of milk that the child has to take. So this is a graded exposure. It is also called oral food challenge, but this has to be done in selected patients. If it is done in carefully selected patients who have been identified as IgE-mediated cow's milk allergy, who have been suffering from cow's milk mediated allergy, then it is very successful. So this has to be done by under supervision of allergists, and if the reactions for cow's milk was severe at previous instances, it has to be done in a hospital. So how it happens, what happens in the immunological mechanisms during allergen immunotherapy or oral food challenge is that when the milk is given, gradually increasing from a very low concentration of 10 to the power minus 6, at some point, the TH1, T helper cell 1 and TH2 balance shifts. So TH1 is the cell which can respond, but also TH2 can, when there's an imbalance between TH1 and TH2, that can cause allergic reactions. This imbalance is matched during the process of allergen immunotherapy. So desensitization has been done in Sri Lanka successfully for many food items such as milk, chicken, beef, fish, egg, tomatoes, coconut milk. So children who are having allergies to this kind of food items have been desensitized and made non-allergic to these food items through this mechanism of desensitization. So there are different desensitization protocols. So I told you our protocol, what we use is 10 to the power minus 6, gradually going up to the level that the patient is decided to take the food. So as I said, I'll reiterate, management of IgE-mediated cow's milk protein allergy. If severe, all forms of cow's milk protein should be avoided. Moderate to mild to moderate, extensively hydrolyzed formula is the first choice. Severe allergy, which requires hospitalization, but which is not anaphylaxis, you can use amino acid formula. And the good thing of this cow's milk protein allergy is that cow's milk protein allergy will gradually disappear as the child grows. So 50% will tolerate cow's milk protein by 1 year, 75% by 3 years, 90% by 5 years, and 95% would only 5% only could continue to adulthood. So during adulthood, the children of 100 children who are having cow's milk protein allergy, only 5% would proceed to become adults who are having cow's milk protein allergy. So this is the modality of treating non-IgE mediated cow's milk protein allergy. Mild to moderate, age more than 6 months, soya milk formula. And then, so if there's improvement, you can shift to normal. If not, you have to shift to extensive hydrolyzed formula. Mild to moderate. More less than 6 months, you have to use extensive hydrolyzed formula or even amino acid formulas. Severe allergy, then you have to always use amino acid formula. So the prognosis depends on non-IgE delayed reaction always develop risk tolerance sooner than those with immediate reactions. Treat at the specific IgE at the time of diagnosis is also very important. So as I said earlier, when you do a blood test, you get a theta. If the theta is very high, then the possibility or the probability of the child continuing to have cow's milk allergy is more. And also the onset is also important. Onset of cow's milk allergy in infancy has the most favorable diagnosis. Late onset has a lesser probability of recovery. So the conclusions are, cow's milk allergy is one of the most frequent food allergies. They can present as IgE-mediated or non-IgE-mediated diseases with varying symptoms. Diagnosis lies primarily on clinical evaluation, supported by skin prick testing, patch testing, measurements of specific IgE, and elimination interaction test. Can be treated with avoidance of cow's milk protein, alternate formula, food and oral immunotherapy. Desensitization is an accepted modality of treatment, and whenever needed, the patient has to be referred to a specialist with expertise in allergy, rather than telling the patient there's no cure for this particular disease. Thank you very much.